Big bubble is the most popular technique for Descemet separation in deep anterior lamellar keratoplasty. It is challenging yet rewarding corneal surgery. It is not always easy to achieve the big bubble. Finding the right depth can be quite difficult at times. What to do when big bubble is not formed? Shall we convert to penetrating keratoplasty now? Or is there any other way we can preserve the descements and the vital layer of cornea? When big bubble fails, what helps? Authors do not have any financial interest to disclose. In the wet lab, we studied extensively on failure of formation of big bubble. We tried to realize what happens at the deeper layer of cornea, what changes take place there. We also thoroughly observed the changes occurring at the posterior surface of the cornea. We noticed multiple tiny bubbles of various sizes and at various depths of the cornea. With the help of anterior segment OCT, we tried to understand the size, extent and location of these microbubbles. Some bubbles are very close to Descemet's membrane, and some have already separated the descements by reaching at the junction of stroma and descements. Now, can these microbubbles be converted to a bigger one? Hypothetically, if one microbubble can be punctured and viscoelastic substance injected, it might be possible to detach the descemet from the rest of the stroma. So we went back to wet lab and see whether it really works. Picked the failed bubble cornea. Layer by layer dissection was carried out. Microbubble nearest to descemet identified. Punctured. Viscoelastic substance injected. Descemet separated from rest of the stroma. Rest of the surgical steps are similar to routine DALK procedure. Now came that big moment when we tried to implement what we learnt at the wet lab in a real life situation. It was a case of advanced keratoconus. Big bubble DALK was planned. Superficial keratectomy performed. Air injected, big bubble not achieved. Repeated at other site, failed again. Air entered into anterior chamber. Layer by layer dissection was carried out. Microbubble nearest to descemet identified. Punctured. Viscoelastic injected to detach descemet from rest of the stroma. Postoperative pictures with anterior segment OCT on day 1 showed good graft attachment. At 3 months, patient regained a visual acuity of 20/30. Coming to another case, where first attempt failed, second time failed again. The third attempt also went in vain, obscuring the entire cornea. So, deeper incision given and layer by layer dissection of stroma was carried out until the desired depth was reached. These steps may have to be repeated until the perfect microbubble was identified. Microbubble closest to descemet identified, and similarly descemet bearing was done. On the first postoperative day, the graft showed perfect apposition. A retrospective analysis of our 80 cases undergoing DALK procedure showed microbubble technique in 22, where big bubble technique failed initially. 3 cases with microbubble technique ended in perforation. Microbubble helped in successful completion of procedure in 19 cases. Identification of the microbubble closest to descemet is of paramount importance when the big bubble is not achieved, and this microbubble can help to preserve the most vital layer of the cornea successfully. Big is ideal, but if it does not turn out perfect every time, even the tiny microbubbles have power enough to deliver good outcomes. Thank you for your kind attention.